Hello everyone, welcome to Ophthal Bytes by EyeToday. Our topic for the day is central serous chorioretinopathy. CSCR is characterized by a localized serous detachment of the sensory retina at the macula due to leakage from the choriocapillaries through hyperpermeable RPE sites. CSCR is most commonly seen in patients with type A personality and those suffering from stress, depression and sleeplessness. It's also seen in pregnant women, patients receiving steroids through any route, and those suffering from Cushing's disease. An association has also been noted between gastroesophageal reflux disease, H. pylori infection, and CSCR. Smoking is also an important factor involved in the development of the disease. Recent studies reveal that men are 6 times more affected than women. But why does this occur? Choroidal hyperpermeability leads to increased hydrostatic pressure, causing a pigment epithelial detachment or a break in the RPE, resulting in accumulation of fluid in the subretinal space, leading to a neurosensory retinal detachment. An optic disc pit could also be a reason for the neurosensory retinal detachment. Infratemporal pits are more commonly associated with CSCR. The fluid causing the sensory detachment could be liquefied vitreous or cerebrospinal fluid. Patients present with a central scotoma, metamorphopsia and decreased vision. Amsler grid reveals metamorphopsia, which corresponds to the serous detachment. OCT reveals an optically empty and neurosensory retinal elevation which is smooth with underlying RPE detachment. Fundus fluorescent angiography can be used to identify the site of leak. The leakage starts as a pinpoint hyperfluorescent spot in the early phase which concentrically enlarges in the late phase, resembling an ink blot. This is seen in 85% of the patients. In rest of the patients, we can see a smokestack appearance in which the hyperfluorescence ascends and expands to form a mushroom or a cloud-like appearance which is due to the increased protein concentration in the subretinal fluid compared to the incoming fluid. In chronic CSR, fluid can sometimes track downwards in a gravity-dependent fashion known as gravitational tract, which is best seen on fundus autofluorescence. How are we going to treat these patients? Keep calm and observe. Observation is considered to be the most standard treatment in acute CSCR. In addition, smoking should be stopped, steroids should be discontinued, and patients suffering from H. pylori infection, antibacterial therapy should be started. Though observation is a standard treatment, in patients where there are vocational needs like pilots or surgeons, when there is a history of CSCR in the other eye with poor visual outcome, and unresolving CSCR for more than 3 months, we need to opt for active treatment. Active treatment involves focal laser, in which the laser is applied directly to the sites of leakage, which has a thermal sealing effect and promotes healing. This is used when it is a solitary, discrete extrafoveal leakage point. The disadvantages are that it can cause a permanent scotoma, RPE scarring, and a post-laser CNVM. Hence, micropulse diode laser is used, which can also be used for the leakage within the foveal avascular zone. The advantage is that it did not cause any scotoma and no functional retinal damage. Photodynamic therapy is also being used in the treatment of CSCR, but with 50% of the dose of verteporfin and 50% of the intensity of laser. Anti-VEGF have also been tried in treatment of CSCR. Though VEGFs are not raised in a patient, anti-VEGFs have been shown to reduce the choroidal hyperpermeability. Medical management includes potassium-sparing diuretics like eplerenone and spironolactone, which was found to decrease the subretinal fluid. Aspirin has also been tried as hypercoagulability is an important factor involved in the development of CSCR. Finally, 50% of patients with CSCR develop recurrence within the first year of presentation. An important point is that depression and other psychiatric disorders were associated with more number of recurrences. Some patients also develop irreversible visual loss due to RPE atrophy, subretinal fibrosis, CNVM, and chronic cystoid macular degeneration. We come to the end of the video and let's meet again with another interesting topic. Thank you.